Assalamu alaikum everyone. I hope you're all doing great, inshallah. My name is Alkatmah. I'm a third year medical student, and today I'll be delivering a lecture on esophageal motility, inshallah. Inshallah, it will be a fairly easy and simple lecture. Nevertheless, please feel free to send any questions in the question box or in the chat. And if you need me to repeat any concept, I'd like to repeat however many times you want me to. And yeah, I also want to apologize in advance because I'm recovering from a bad flu and will be coughing a lot. And I know this is annoying, so I'm sorry. But yeah, let's start. Bismillah. Okay, so the learning objectives here are the exact ones that you guys have from Dr. Angelica's lecture. However, in a nutshell, I'll be just going over the first the basics of the esophagus, the structure and the function, and then we'll be going over the swallowing phases and how it's controlled by the nervous system. Third, I'll be going over the esophageal manometry, and fourth, I'll be going over some clinical correlations such as the achalasia and GERD, inshallah. Okay. So to begin with, just starting from the basics to orient ourselves, the structure of the esophagus. So we all know that the esophagus is part of the GIT, or the gastrointestinal system, and it starts right after the oral cavity or the mouth, and then till the start of the stomach. So for anatomical reasons, anatomists divide the esophagus for 3/3. So the upper third, the middle third, and the lower third. The upper third is consists of, like, that's what you should know about this, is that the upper third consists of skeletal muscle. The middle third consists of both skeletal and smooth muscles, and the lower third consists of smooth muscles. From this, what can we infer? What do we know? What is a big main function that separates the skeletal from the smooth muscle? You guys can write in the chat or unmute yourself. I do not mind. Okay, so it is that the skeletal muscle is more voluntarily, or we can control our skeletal muscles, and the smooth muscle is autonomic or involuntarily, so we can't control it. This makes sense because when you think about it, the upper third of your esophagus is the part where you can voluntarily swallow your food. So, and then as you go down, you really lose control of it, and it becomes almost all autonomic or involuntarily. For the nervous supply of this, we know that it's nervated by motor, like the motor and sensory fibers are nervated by the vagus nerve. And so the skeletal muscles are nervated by the minteric plexus. I'm sure you guys have covered this like before somewhere. And the smooth muscle is the enteric nervous system. The enteric nervous system is one of the three categories under the autonomic nervous system. And yeah, from that you can infer that it's involuntarily. Okay. On this image right here, you can also see the functions, the different kind of functions. I'll be going over them in the next slide. So the functions of the esophagus fall under two main categories. The first is the propulsive, and the second is protective. When I say propulsive, what word comes to your mind? Like I'm sure you guys have covered peristalsis, right? Can you guys tell me what it means or anything? Okay, so peristalsis is the movement of the rhythmic movement of the bolus of food through the esophagus, through contraction and relaxation. I'll be repeating this word a couple of times throughout this lecture, and so it's really important. And a bolus of food, a bolus is just the food after it has, when it reaches your esophagus, it's called a bolus. And so yeah, the propulsive functions are to direct the food bolus into the esophagus, that's first, and then to transport it all the way down, and then to the stomach. The protective functions are to prevent the air from entering the esophagus. We'll cover this also when we cover the upper esophageal sphincter. And to prevent the regurgitation of food. This is also, we'll cover this when we talk about the lower esophageal sphincter. And then also to clear any material from refluxing back from the stomach to the esophagus, also LES. And yeah, that's the same thing. If I go back to the diagram here, we can see how those functions are divided based upon the thirds, the 3/3 of the esophagus. So the first upper third, we can see that it directs the food bolus into the esophagus and prevents the air from entering, and also prevents regurgitation of food from the oral cavity. In the middle third, we can see that it transports the bolus down through the esophagus, and that it clears any material reflux from the stomach. And in the lower third, we can see that it's still directing the food bolus into the stomach, and it prevents regurgitation of acid gastric contents. And yeah, that is mainly it for the structure and function. Now we start with the second objective, which is the swallowing. Before we start, do you guys have any questions at all? Is everything clear? Okay, I'll take this as a yes. Inshallah, everything's clear. If not, please do stop me or write in the chat box. Okay, so swallowing is a reflex that is a sequence of events to propel food from the mouth to the pharynx, to the esophagus, and to the stomach, and lastly to the stomach. It is it's mediated by sensory impulses, which are also called mechanoreceptors, that sense the food bolus in your oral cavity, and then to your esophagus, and so this is all controlled by an area in the medulla and pons called the swallowing center. I heard from Dr. Angelica's recording, I heard her repeating this like a couple of times, so just make sure you know this. There's not much to understand about it. Just memorize that it's controlled by that the swallowing phase is controlled by an area in the medulla and pons called the swallowing center. Okay, and from there and yeah, so you should also know that the motor impulses are controlled by the cranial nerves, which are, we'll mention them also in a bit. They're cranial nerves 7, 9, and 10, I assume. And this is about it, swallowing, and this is a very important medical term you should know, which is dysphagia. I'm pretty sure you guys have heard of it. So dysphagia is just the medical term of difficulty in swallowing. That is it. But you guys have to make sure that you know this, because in case it appears in any of your questions, you're clear and set, and you don't get confused as in what does this mean. Yeah. So this is the swallowing phases that I'll be discussing. You can check this as in like the time and seconds are down on the x-axis, and it's divided by 3 parts. So bolus in mouth, bolus moves through the pharynx and upper esophageal sphincter. Wait, I'll check if I can write. I don't know how. خلاص, it's okay. I'll just use the cursor. So bolus in mouth, bolus moves through pharynx and upper esophageal sphincter, and then bolus enters the esophagus. So we can check, we can see that first, the tongue thrusts up and back. This means that, like, let's think of this as a story. So imagine that you're now having your favorite kind of, I don't know, pizza, and you take your first bite, and now the pizza bite is in your mouth. You're crunching it, you're eating it, and everything, and then it turns to a bolus and needs to be sent to the esophagus. So what the tongue does is that it thrusts up and back in order to push this bolus up, in order to push this bolus posteriorly to go to the nasopharynx and down the esophagus. So from there, the nasopharynx close. This is to prevent the bolus from going up to the nasal cavity. We'll see this in diagrams, and we'll repeat this like a couple of times. This is just a quick overview. And then the larynx is elevated in order to close the airway so that the bolus does not end up going to the trachea. This will also cause aspiration of the food that is unneeded in the trachea, or what we call as choking. And then the upper esophageal sphincter will open as it senses the bolus coming to it in order to allow it to go down the esophagus. And the pharynx contracts to just push it down. Yeah, so here is it written in words. So we can go over again. So again, it's divided into 3 stages. First is the voluntary oral stage. This is the first step of the 3 stages. As we said, it's voluntarily because you it's controlled by skeletal muscles, and you voluntarily choose to swallow food, a piece, like a bite of food or not. So what happens here is that the tongue thrusts up and back, and in order to posteriorly push the bolus down the esophagus, and this is also controlled by the medullary swallowing center, as we mentioned before, and the cranial nerves 7, 9, and 10. Okay, the second stage is called the pharyngeal stage. The pharyngeal stage begins when the bolus enters the pharynx. So again, we talked about how it triggers signals to the brainstem. These signals will cause a series of actions that are really so important, and they are also like very sensible. So you guys can inshallah easily memorize these. So think of it. We close first the soft palate in order to block the food or the bolus going to the nasal cavity. Then we also block the tongue thrusts up to block the oral cavity. This is to prevent the bolus from coming back again to the oral cavity, which is unneeded. And the vocal cords close, and the larynx moves up and forward. This will allow the epiglottis to cover the airway to prevent the food from entering the trachea, which is the wrong passage or passageway for the food. And this is like what is known as choking. And also the esophagus opens, which is the upper sphincter, and allows food in. And then the peristaltic waves will continue the work by pushing the food into the esophagus. And third is the esophageal stage. The esophageal stage is just the rest of it, which is what we also covered as peristalsis. So we know that the upper esophageal sphincter opens first, and the presence of this bolus in the esophagus will stimulate the mechanoreceptors and the reflex pathways to start the peristalsis. Again, peristalsis is the alternating contraction and the relaxation of the muscles. So what happens is that the part above, like the part of the esophagus right above the bolus contracts. This is to push the bolus down, and in order to help this even more, the part of the esophagus just below the bolus dilates in order to give it its space to move down. I hope you guys understand this. And yeah, the striated muscle is, as we said, the skeletal muscle here, and the skeletal muscle is regulated by the nucleus ambiguous in the brainstem, and the smooth muscle is regulated by the parasympathetic outflow via the vagus nerve. when it comes to innervations, I advise you guys to just memorize them. As in, like, there's not much understanding that you can do now. Inshallah, you'll be able to understand them more when you go second year, neuro, inshallah. But for now, just memorize them because they do tend to ask about these and they're just pure recall questions. So yeah, just memorize those innervations. And here is the definition of peristalsis again. And this process is referred to as receptive relaxation. And yeah, this is it in a diagram, just in order to make sure you guys get the hang of it. So yeah, this is the bolus of food. This is as you start eating. It's moving back. Here you can notice that the nasopharynx is, or the soft palate is still not blocking the nasal cavity, and that the epiglottis is still not blocked too because we are breathing. And yeah, the oral cavity is not blocked either because we're still eating. And then when you go to the second phase, which we called, do you guys remember what was the second phase called? The first phase is the voluntary oral. The second phase, it is the pharyngeal stage of swallowing. Third is the esophageal. So pharyngeal stage, just memorize how everything's getting blocked here. So the soft palate blocks the nasal cavity in order for the bolus not to go up to the nasal cavity. I'm sure you guys have experienced this before when drinking water and laughing or something. It's really embarrassing, but the water does come out from your nasal cavity. So this is bound to happen if the soft palate does not block it. And the tongue blocks the oral cavity, as we said, to prevent the bolus from going back to the oral cavity. And the epiglottis closes the trachea in order for the bolus not to go, not to be aspirated through the trachea and the patient would choke, or the person. Yeah, this is the third stage, which is the esophageal stage. You can see that the bolus is going down the esophagus and everything is unblocked again. So you can breathe, you can, the tongue is going down, the epiglottis is up, so everything is good. And because the bolus, خلاص, it's going down the esophagus, and that is how the swallowing phases are done. I hope all is clear. Here's the first checkpoint. Do you guys have any questions? By now, we have finished the first objective and the second objective. So this is like almost half of the lecture. All clear? If I'm going too fast, let me know. Or if I'm going too slow, let me know. The esophageal stage? Okay, sure. I'm going to repeat the esophageal stage. So this is mainly what happens at the end. So as we said here in the diagram, that because when the bolus is going is like going from the oral cavity to the esophagus, we're blocking three passages or pathways, just so we prevent the bolus from going to the wrong direction or to the wrong place. And خلاص, when the bolus goes to the esophagus, there is no need to block anything anymore. So we can breathe. The epiglottis is up, the soft plate is down, and the tongue is down. So it's here. It is in words. All you need to know from here, that other than what I just said, is that the skeletal muscle is regulated by the nucleus ambiguous, and the smooth muscle is regulated by the vagus nerve. All good? Alhamdulillah, great. I might be repeating some concepts like so many times in this lecture or this presentation. This is because I want to ensure that everything is covered, and the repetition really helps when it comes to memorization. So inshallah, by the time you finish this PAL, inshallah, you'll be like able to recall like at least 50% of this, if not more, inshallah. And yeah, nevertheless, I'd really like, I wouldn't mind to repeat anything, no matter how many times you tell me. So This is again the peristalsis that we were talking about. This is just for anyone out there who's a visual learner, like I am. So this is to show that the contraction here is happening above the bolus. This is the part of the esophagus that is just above the bolus. So we contract it here in order to push it down. And to help in this too, the part below the bolus is dilating to allow a space for the bolus to go down too. And yeah, this is like how it goes. So like there's contraction, relaxation, contraction, relaxation. Like it's a rhythmic sequence. And yes, so esophageal manometry. This is a diagnostic procedure. It's really important in when it comes to esophagus function and diagnosing esophageal diseases. So just like first, so a quick definition of the esophageal manometry. It is just a diagnostic procedure that is used to evaluate the function of the esophagus. Like I said, what happens here is that the doctor inserts a very narrow tube from the nasal cavity of the patient down to their esophagus. And this tube has the ability to measure the pressure of the esophagus. The reason they insert it from the nasal cavity, not from the oral cavity, is that because while it's inserted, they would ask the patient to swallow or drink something so that they will be able to assess or to measure how how good the esophagus is functioning, or if there is anything any abnormal happening. So yeah, this is the diagram. I'll be going over all the steps in more details but this is the diagram for you guys to be oriented. So we start from the upper esophageal sphincter, then down to the esophageal body, then to the lower esophageal sphincter, and yeah, all the way down to the stomach. So the upper esophageal sphincter. This upper esophageal sphincter, as we said, is the voluntary controlled one. Okay. As you can see here in the diagram, that at first it is at resting point. This is because, if you guys remember this, we talked about this in the protective functions of the esophagus. This is to prevent the air from entering the esophagus while at rest, and also to give the esophagus a break or to relax it during swallowing phases. Okay. Then when the swallowing begins, the bolus passes, as we said, from the oral cavity to the upper esophageal sphincter. And again, we mentioned that the presence of the bolus in the esophagus or in the upper esophageal sphincter will stimulate the mechanoreceptors. If you guys still do not really understand how mechanoreceptors work or what are they, just think of it as mechano comes from the word mechanical. Mechanical as in they're mechanically pushing on the walls of the esophagus. This causes the receptors there to be stimulated, and which causes signals to the brain, which allows for certain events to happen, such as here the decrease in pressure of the upper esophageal sphincter, or the UAS. This is because it opens. You guys can see here the drop. Can you guys see that? This drop here is because esophageal sphincter opened. Just put it as a rule of thumb that whenever the esophagus is opening, the pressure is dropping, and whenever it's closing, the pressure is increasing. This kind of makes sense because if I like to think of this like a small room or container. Whenever it's closed, there is more pressure inside. Pressure. What we mean by pressure here is the atom's pressure, the pressure that is inserted by the atomic particles. You get me? Okay. So as I said, there will be a decrease in the pressure of the upper esophageal sphincter because it opened. As soon as it opens and the bolus moves down the upper esophageal sphincter, we need to close it, right? So closing it, as I said, will cause an increase in the pressure of the upper esophageal sphincter. And from there, the peristalsis will begin. And which peristalsis exactly? It's the primary peristalsis or the primary wave. Okay, so here it is again. So rest goes down, up, and then resting again, because we're only talking about the upper esophageal sphincter here. But because خلاص the bolus now is moving down, as you guys can see here. The esophageal body, like as we move down the esophageal body, there is no more resting, as in like resting, because the esophagus is like a little bit هيك شوي it's moving, not resting much. But when a bolus is present there, you guys can see the quick like increase in pressure in the esophagus, and this is what we call as in the esophageal body phase. So the part of the esophagus, this is just a repetition of what I said before. So the part of the esophagus above the bolus will contract. What causes this contraction? We said the myenteric plexus. What neurotransmitters exactly? This is what you guys have to memorize. It's the acetylcholine, so ACH, and the substance P. These two neurotransmitters are always known as the activatory neurotransmitters. So they work on activating or contracting the muscles. All right. Just like this is a very general knowledge to have throughout like all medicine, because you'll like hear this. I'm already sure also you heard this before. And yeah, so as I said, this contraction will cause the bolus to move down and will like crush it a bit in order to like there is not much of crushing, but just like in order to push it down. Push it would be a better word. Okay, so then as I said, the part of the esophagus below the bolus will dilate, and this is by the vagus nerve. And what exactly are the neurotransmitters? It's the nitric oxide, which is NO, and I believe this is called vasoactive intestinal protein or something. I'm not sure. But the VIP. So also these two are also very much well known to be inhibitory neurotransmitters, because we do have many more inhibitory and activatory neurotransmitters, but those two are most known for it to be activatory, and those two are most known to be inhibitory. Okay, so by inhibiting that part of the smooth muscle of the esophagus, it will cause the dilation. You guys get where I'm going at? And this will allow the bolus to move down. Again, here is just like two definitions of the primary peristalsis and secondary peristalsis. Primary peristalsis is simply put just the first wave of peristalsis that goes when you start eating, and this is controlled by the vagus and is initiated by swallowing. The secondary peristalsis is is initiated by the entry of food into the esophagus. So it just means that it will happen, like another wave of peristalsis will happen again for the same bolus. This is just to make sure that the bolus is cleared up very well from the esophagus, and that there are no more residues left in the esophagus, in order not to irritate the esophagus or something. Okay, because as you guys very much well know, that the esophagus is like the esophagus does not work or does not function as a reservoir. This is like this function is more of the stomachs and the intestines when it comes to the GIT, but the esophagus is only for transport and peristalsis, as we said, and for some protective functions, as we discussed in the beginning of the slides, but not at all for reservoir. So yeah, this is why the secondary peristalsis is important, to make sure that all the bolus is emptied out from the esophagus into the stomach, and this is mediated by the stretch receptors and the enteric nervous system. All right. Okay, so moving down to the lower sphincter. If you want, let's first like visualize this. So you guys can see here the wave of the upper. So when dividing the esophageal body, we divide it also to upper, middle, and lower, right? So the upper part here it spikes up first because of course that's where the bolus goes first, and then it would go down. The middle part would spike up right after because the bolus is there, and the fourth part will spike right after the third because خلاص the bolus is moving. So as you guys can see, it's moving to the right, okay? And yeah, this is just to show that the bolus, where is the bolus exactly, or the mechanoreceptor effect of the bolus, or the bolus effect on the mechanoreceptors, okay? And now we reached here, so LES, or the lower esophageal sphincter, okay? So lower esophageal sphincter maintains adequate resting pressure to prevent the stomach contents from reflexing into the esophagus. We've mentioned this now for a couple of times, but again, just how upper esophageal sphincter has to rest in order not to in order to prevent the air from entering to the esophagus and to relax. Also, the lower esophageal sphincter has to rest to prevent the stomach contents from refluxing into the esophagus. I'm sorry. Okay. So we'll be covering this more, like this aspect or this idea, when we go to clinical correlations and GERD or gastric reflux. But yeah, just know this for now. I know how important it is. And then so when the lower esophageal sphincter is not resting anymore and the bolus has arrived to the lower esophageal sphincter, it has to relax. By relax here we mean that I don't want you guys to be confused between resting and relaxing. Resting, it means it's just closed. It's not open and it's not contracting, okay? Or resting can be more of contracting because it's like stopping or inhibiting anything from going down. But we will also go to another clinical correlation right now where the esophageal sphincter is really contracting. This will cause achalasia. But that's why I want you to know the difference between resting, relaxing, and contracting. In the normal case, when there is no bolus, it's just resting, okay? When the bolus arrives, we need to relax. When I say relax, I mean open, like open wide, so that the bolus is, the bolus will be allowed to enter the stomach. And as we mentioned this before, that whenever we say relaxing or dilation of the muscles, that means it's brought upon by the VIP and the NO neurotransmitters through the vagus nerve, okay? And this is what caused the big drop in pressure. I'll show you guys here. Can you guys see this like drop in pressure? This here is, as I said before, when we were discussing the upper esophageal sphincter, we said that a drop in pressure means that the esophageal sphincter is opening. So when the bolus has reached to the ES and it wants to move down to the stomach, it needs to open, and its opening is pressure dropping down, okay? And then the pressure goes back up as the LES closes back and the bolus has entered the stomach. Okay, makes sense. You can also visualize this here because as we said, the esophageal closes up. That means the pressure goes up. Okay. I really hope this makes sense, as manometries sound to be شوي هيك not very like easy or intimidating, but they really are, like once you get the hang of it. These are just some notes I wrote here just to make sure that you guys understand that the proximal stomach is also relaxing with the lower esophageal sphincter. This makes sense again because if the lower esophageal sphincter is relaxing, the proximal stomach or the upper part of the stomach has to relax accordingly in order to accommodate the bolus coming, right? And another point is that the upper esophageal sphincter and the lower esophageal sphincter are never open at the same time. So if I'm eating and the bolus has arrived to the upper esophageal sphincter, I can't and خلاص يعني it goes down, the upper esophageal sphincter closes. I can't open it again unless it's either like down in the stomach or before like it has reached the lower esophageal sphincter, because our body is designed in a way that the upper esophageal sphincter and the lower esophageal sphincter cannot be open at the same time. Okay, just know this. Don't go into more details about this, because inshallah you'll be learning maybe more about this later on. But for now, just know this. And another note is that the gravitational effects decrease the passage time of like the bolus from 8 to 10 seconds to 5 to 8 seconds. Okay, so I'm sure like all of us before we got into medicine, we thought that swallowing is purely like, or maybe when we were young, or maybe that's just me, I don't know, but swallowing is mainly just brought upon by gravity or something, and that if I were to like do a handstand or something, I wouldn't be able to swallow. But that's not true. Gravitational effects help swallowing, but they are not the reason we swallow, or they're not the main reason that brings upon swallowing. We know now that peristalsis is, and it is the movement of muscles, as we said, with rhythmic movements of muscles by contraction and relaxation in order to push the bolus or the food down to the stomach. All right, this is the other checkpoint. How are we doing? Is everything all right? Do we get everything so far? Okay, perfect. Again, if you guys need me to repeat anything, I'll be more than happy to do so. Or if I'm going fast or anything, please let me know. And yeah, I just wanted to let you know, to like tell you that the manometry graphs can be asked upon. Like they might give you the graph and like along with a question, and like ask you a question on manometry. So maybe like what stage is, or like is this, or like, because now when we learn about the clinical correlations, we'll discuss like what will happen to the manometry if things were to go wrong. So you guys have to understand and memorize the manometry in the normal condition, the normal physiological condition, in order to understand it and differentiate it from the pathological one. Okay? And yeah, with that, we are done with all the physiological, normal conditions of the esophagus. Now we're going to start with the clinical correlations. Clinical correlations are mainly two diseases or like pathologies. And it's mainly like the lower esophageal sphincter. Like this is what has been discussed in your lecture. So the first one is the achalasia. Achalasia. I think you guys by now know that the prefix A means the absence. Okay, so achalasia means that like there's an absence of something. Okay, so what is achalasia? It's a primary esophageal motility disorder characterized by the absence of esophageal peristalsis and impaired relaxation of the lower esophageal sphincter in response to swallowing. When saying this, I mean that the, like, just simply put, the lower part of the esophagus and the lower part of the esophagus is does not have peristalsis anymore, does not work properly, and the lower esophageal sphincter is impaired in a way where it does not relax. It's contracted and it always stays like that. So it does not allow any bolus or any food or drinks to go through or flow through to the stomach at all. Okay? And if you think about it, when we discussed how the normal physiological peristalsis happens, or how the esophageal sphincter happens, the lower esophageal sphincter opens, we were discussing it in terms of muscles and innervation. So if there's a problem here, it's either the muscles or the innervation, right? And when it comes to achalasia, it is due to impaired mesenteric plexus that prevents the LES from relaxing. Remember, we mentioned mesenteric plexus before, and yeah, this is just like a case where degeneration of the mesenteric plexus happens, and so it won't be able to signal or send neurotransmitters for the muscles to relax. So it stays contracted. What neurotransmitters are what two main neurotransmitters um like cause or bring about relaxation? I mentioned this more than one time. Please, guys, answer this. Like, this is very important to know. It's mainly two. No one, please. Okay, so what two neurotransmitters bring upon relaxation of the smooth muscle or allow the lower esophageal sphincter to open? We said there are two that are activatory or they contract the muscle, and two that are inhibitory or relax the muscle. So what are the two inhibitory ones? Yes, perfect. Perfect, Talia. I'm so happy. So the nitric oxide and the VIP. The NO and the VIP. Okay, so now we know that it is a problem regarding those. And as I said, this will cause the bolus to be stuck in the lower esophagus. And if the food is stuck there for a long time, it will like very sensibly cause the dilation of that part. Okay. Now the way that they'll bring this question, I'm sorry, the way that they'll bring this case or scenario, so they tell you that a patient presented to the clinic with dysphagia. What did we say dysphagia was? Yes. So inability to swallow. So the patient presents with inability to swallow or dysphagia and heartburn and chest pain. And this is because of the regurgitation that is happening from the undigested food. Okay. And also weight loss. Weight loss because makes sense also because the food is not being able to like go to the stomach and to the intestines. We can't get the nutrients, we can't get the fats or anything. So, and we can't eat. So weight loss. Okay. So just put in mind those like main points when it comes to achalasia. First, absence of lower or mid-lower esophageal peristalsis. Second, impaired relaxation of the lower esophageal sphincter, so it's always contracted. Third, impaired mesenteric plexus or like impaired and NO and VIP neurotransmitters like from coming or from activating this. And yeah, just dilated lower esophageal because of the food that is stuck there. This is it. This is mainly it. I'm pretty sure if like any question were to come, it would be this or this. This is the golden standard diagnostic way to diagnose the achalasia. So I put gold here to just for you guys to remember. But what we do is we do a barium swallow test. Barium is a contrast that we give the patient to drink while we're doing an X-ray. Okay, there we can like the X-ray can capture or can show us how the barium is going. Okay, and whilst moving through the esophagus down to the stomach, we will be able to notice this appearance. This is a very high yield appearance. I remember getting this in my exam, and I'm pretty sure that every batch gets this question at least once in the exam. It's called the bird's beak appearance. Why bird's beak? Because I put another picture here to show you guys because here's a bird beak, but you guys can like imagine the bird's beak being here and the bird head here and then the bird's body being here. If you guys can imagine this, yani. But yeah, it just shows the dilation of the lower esophagus, and yeah, this is how like we diagnose achalasia. Okay. And lastly, when it comes to achalasia, if they don't ask about either all of the things I mentioned here or the barium swallow test and the bird's beak appearance, they might ask about the esophageal manometry when it comes to achalasia. So as I said, now that we know how the manometry works physiologically normal, we have to memorize how it goes, or how it works when there's a disease. Okay, so when it comes to achalasia, I'm sorry, there is absence in the peristaltic contractions in the lower esophagus, right? If we said there is no peristalsis in the lower esophagus, that means the pressure will be down or more up. Like, will it decrease or increase? Like, low peristalsis means more or less pressure. No, actually it's decrease. Here you guys can see the manometry. Please don't don't focus on scleroderma or diffuse esophageal spasm at all. They were not mentioned in your lecture. However, I saw this like diagram on the internet and I thought it was most useful to show the difference. Here's the normal manometry and here's the achalasia manometry, okay? The upper esophagus, like the pharynx and the upper esophageal sphincter, are exactly the same, like no difference at all, because the problem is not there, okay? However, when we start going to the esophagus, you can see that the upper one is starting to decrease, okay? Like barely there, okay? The middle and the lower ones, the middle and the lower parts of the esophagus, they're decreasing in a very very you can easily tell this, okay? So the middle is also like not that much, but the lower is the most like easy way to tell that there is achalasia there, because خلاص it's like barely even there, okay? And what happens to the lower esophageal sphincter is the exact opposite, because we said that there are no peristalsis here, right? So there is decreased pressure. However, in the lower esophageal sphincter, there is increased pressure. That's because the lower esophageal sphincter fails to relax. It's just contracting and contracting and contracting, so there is more pressure induced. So this will show you, this will appear in the manometry as, like, if you guys can see that drop here, it's still a drop here because the esophageal sphincter is opening. It's not gonna go up, but you can tell that, like, here's the 0 pressure and here's the 80 pressure. It goes up, like this whole thing moves up, okay? And this is also another sign to tell that there's achalasia from the manometry, okay? And yeah, it's just written here. So absence of peristalsis in the lower esophagus means lower pressure on the manometry. Increased pressure in the lower esophageal sphincter at rest because of the failure of the lower esophageal sphincter to relax during swallowing. Alright? I hope that makes sense. Is that really clear? Because Ajad, it's high yield. It's really high yield achalasia. I hope you understand it fully, because I'll be moving to the last clinical correlation, the last part of the lecture, and then we'll be doing questions, inshallah, and wrapping it up. So yeah, last clinical correlation is GERD. GERD is also known as gastroesophageal reflux disease. I'm pretty sure we have, like, most of us have experienced this before. It's what we normally call, in non-medical terms, heartburn, okay? Heartburn, because like you feel this sensation or you feel this burning in your esophagus because of the regurgitation of the acid reflux. For those of you guys who don't know what regurgitation means just the flowing back, okay? So the acid reflux will go back to the esophagus, okay? Where it shouldn't be. The acid reflux should stay in the stomach, because the stomach is built, like the epithelium and the structure of the stomach is built to endure this acid reflux. However, the esophagus is not. So if in any case the acid reflux regurgitates to the esophagus, it will cause this heartburn sensation and inflammation, and as a chronic, like in the long term, it will cause a cancer. But I'm not going to go. I won't be going to through this, because It was not mentioned in your lecture, and you will be covering this inshallah later on. But just know that this cancer is happening because of the change of like cells, because the acid reflux is going to a place where it's not supposed to be. So yeah, this will cause like a disease or cancer. Anyways, so it's a condition in which stomach acid repeatedly flows back up or regurgitates into the esophagus due to three reasons. Reason number one can be incompetence of the LES. When saying incompetence, I mean that the lower esophageal sphincter or the LES is not working properly. Okay, so it's malfunctioning, or it's not contracting or closing or resting as it should be. It's like always open or something. Okay, and مش شرط إنه it's open like 100%. It can be open for like just a little bit, and still the acid reflux will be able to regurgitate back. Okay. Another reason could be the weakness of the diaphragm. We know that the diaphragm sits right above the stomach here. I think I have it in one of those. Yes, here's the diaphragm. It sits right above the stomach, right? Okay, so from that we can know that if there were to be any weaknesses in the diaphragm, such as hernias, I'm not sure if you guys have covered hernias yet. Hernia means a weakness in the diaphragm, which causes a distension of the diaphragm. If the diaphragm is distended or weakened, it won't help in closing the esophagus. Not closing the esophagus or the lower part of the esophagus when it should be closed, again, brings about acid reflux. Okay? And another reason is increased gastric acidity. This can be caused due to like diet like changes, or like drinking or having acidic food such as like coffee or like other like stuff. Okay, so yeah, increased gastric acidity. Okay, so the consequences of this would be reflux esophagitis, which is what I said is the esophagitis. By now I think you guys know that the suffix itis means inflammation. So esophagitis means inflammation of the esophagus. Reflux is because it's going back, it's refluxing. So reflux esophagitis, inflammation of the esophagus to the reflux. Erosion also means like changing of the esophagus cells or epithelium due to the esophagitis, as I mentioned it, which causes cancer. Then there's also sensation of heartburn, which is what we usually call it, and esophageal bleeding and strictures. So this will come as, or like appear as like vomiting blood, or yeah, irritation of the larynx and coughing or asthmatic symptoms. Yeah, this is also what I mentioned, and just know this as it's mentioned in your picture. Okay, here's another picture to demonstrate the GERD. So you can see here that in a healthy stomach, the lower esophageal sphincter closes when it's supposed to be closed, when there's no bolus coming, and nothing wants to go down, because we don't want the acid reflux to happen of the stomach. Okay. However, in a GERD stomach, the lower esophageal sphincter is incompetent, so it does not close or does not function well, and this will cause the acid reflux to happen. Okay. In order to compensate for this, the body tries to bring about secondary peristalsis, which I told you guys about, is the another wave or a second wave of peristalsis that comes after the first one, just to make sure it is clearing all the bolus down to the stomach. In this case, there won't be bolus, but it's trying to clear the acid reflux or preventing it from happening. Okay, because peristalsis is also like contraction of the lower esophagus. And also stimulation of salivary secretion. This is to neutralize the acid, because the salivary secretions will be more alkaline, and by that the acids will be neutralized and we won't feel that heartburn sensation more often. And when it comes to like a clinical scenario or the exam question you guys are going to get in your exam, they'll most probably mention that the patient is pregnant, obese, or has a weakness in diaphragm. Okay, so this will also help you to guess or know the disease from the very first beginning of the question. So beginning of the question, they say um, a, a, a patient, a pregnant woman, or an obese man, or a patient with a history of hiatal hernia, like a diaphragm hernia or something, presents to the clinic with a heartburn sensation and like maybe some dysphagia or something, or irritation of the esophagus and stuff. What will be the answer? It will be GERD. They might not. They might mention GERD for you in the question and ask you about something else. So maybe they might tell you that the doctor finalized or came to the result that the patient had GERD, and then they'd ask you what causes GERD, like what are the reasons. So you'd either say competence of the LES, weakness of the diaphragm, increased gastric acidity, or you can say reflux esophagitis, erosion, sensation of heartburn, and esophageal bleeding strictures, or so and so. Okay. This can be like maybe they would mention too in the clinical scenario that the patient is trying to not have any like food or meals directly before sleeping. This is because when you sleep, you're lying supine, and you're even helping, like you're not even and you're helping your gastric acids to reflux even more because the gravity is not working as much, and yeah, you'll feel it more. You'll feel more of the heartburn sensation, and yeah, I think this is about it. Do you guys have any questions before we start answering my questions? All right. Okay. Alhamdulillah. So here's question 1. I'll read it for you guys. You can answer in the chat box and we'll discuss it. So, which of the following substances is released from neurons in the GI tract and produces smooth muscle relaxation? We've mentioned this like maybe 4 times, 5 times now. D. Perfect. Perfect. Everyone's saying D. So D, vasoactive intestinal peptide. What would be another one? Yes, NO. Perfect. So happy. I'm so proud of you guys. Okay, question 2. A 56-year-old man complains of increasing difficulty of swallowing over the past 3 years. A radiograph taken after swallowing barium shows a distended esophageal body. A manometric study supports the diagnosis of achalasia. Which of the following correctly describes the physiological change associated with achalasia? Okay, so this is like one of the scenarios or examples where I'm like, in the way I mentioned it to you guys. So they'll tell you what the diagnosis is, but they'll ask you about something else, about this disease. So in this case, they're asking about the manometry. Remember what changes happened in the manometry? We said that the first half is, or the upper half is good. Okay, so I'm having a D in the chat. Anyone else wants to give it a try? Okay, another D. D or C? Yes, the answer is C. The answer is D. Sorry. No, it's not E. Why? Okay, let's go over this. So in D, you can see that the elevated pressure of there is no elevated pressure of the upper esophageal sphincter, and that is true because we said that when it comes to achalasia, it's mainly a disease of the lower esophagus and the lower esophageal sphincter. So the upper esophageal sphincter would not be affected whatsoever. So there won't be elevated pressure because it's closed. Why would the pressure be elevated, right? And there's no diminished peristalsis in the upper esophagus. Again, does not have to do anything with the upper esophagus. We're talking about the lower esophagus here. There is diminished peristalsis in the mid to lower esophagus. Yes, we mentioned this, and we did see it in the manometry. I'll show the manometry to you guys now in a second. And there is elevated pressure of lower esophageal sphincter before swallowing, right? Because we said the lower esophageal sphincter is contracting too much, that the pressure is increasing, right? And there is incomplete or absence of the lower esophageal sphincter relaxing after swallowing. So as we said, the lower esophageal sphincter is not relaxing as it should be. It's more contracting. This is what will cause the elevated pressure. I hope it makes sense now. I'll show you guys the manometry real quick. Okay, let's see. So again, we said that the pharynx, the upper esophageal sphincter, the upper esophagus is all perfectly normal. Okay, it's when you go to the middle and the lower esophagus where you start to see the changes happening. So it's going down, and then in the lower it's barely there. In the lower esophageal sphincter, okay, the wave is still down, and this is because the the um the sphincter is opening. Yeah. So I mean the sphincter is contracting, I'm sorry. So it is still, the wave is still going down, but however the whole thing has shifted up. Shifted up means there's more pressure, because you guys can see the numbers of the pressure here. It's 0 and then 80, up to 80. So if it's going up, the pressure is increasing. Makes sense? I hope whoever answered the with C or E makes sense. Okay, great. Okay, last question, and we'll wrap it up for today. 45-year-old man comes to the clinic complaining of burning chest pain that has been progressively worsening over the past 6 months. The pain is most noticeable after meals and when lying down. He reports a sour taste in his mouth and occasional hoarseness in the morning. He has no history of smoking or alcohol use. On physical examination, the abdomen is soft, non-tender, and without organomegaly. I'm sorry. Cardiac examination is unremarkable, and EKG, I'm sorry, shows normal sinus rhythm. He is prescribed a trial of a proton pump inhibitor. Which of the following best describes the underlying pathophysiology of this condition? Because the clinical scenario is a bit long. However, please do not get intimidated by long clinical scenarios. For some reason, they tend to be the easiest most of the times. So let's break this down. 45-year-old man شو اسمه comes to the clinic with burning chest pain. From this, you can first infer the heartburn sensation. Okay. Now we start thinking of a disease in our mind, right? And it's over the past 6 months, so it's more chronic, not acute. Okay. The pain is most noticeable after meals and when lying down. I said that when we lie down, we prevent the role of the gravity, so the gastric acid reflux is more prone to happen, right? There's also a sour taste and hoarseness. These are more symptoms that come when we talk about this disease, but you guys have not mentioned them much in your lecture, but it's good to know. It's okay. There's also no history of smoking or alcohol. And then the abdomen is soft, so there's like abdomen physical examination and cardiac examination is normal and unremarkable. And at the end, we said that he's prescribed proton pump inhibitor. Proton pump inhibitors, I'm not sure if you guys have covered them, but they're basically like they're inhibiting the gastric acids. Okay, so again, this all goes back to which condition, as you guys are saying here, it's B. Dysfunction of the lower esophageal sphincter. Good, yes. Perfect. I'm so proud of you guys. MashaAllah. MashaAllah عن جد, you guys look like you are all fast learners. وإن شاء الله this whole lecture has been like easy and will be easy for you guys, as well as like the exam questions and all. Thank you so much for listening. This is actually my first PAL ever, so I hope I did a good job. And if you guys have any questions, like, or want me to, like, if you have any comments on my paths or anything that you want me to know, please, please, please send them my way. I have my contacts in the first slide, so my number and my email. And yeah, if you need any questions or any help at any time, please let me know. I'll be more than glad to help you guys. Here's the QR code that you can kindly scan to share your honest feedback. And yeah, thank you guys so much for attending, and I hope you benefited.